My current understanding compels me to formulate the following brief answer. If both type 1 and autoimmune and type 2 a lifestyle diabetes are pulled together, I describe them with the unifying name, fuel partitioning disease of insulin. Now, that's not to say that type 1 diabetes does not have a strong lifestyle component as well. You may rightfully ask what I mean by fuel partitioning disease. Understanding the physiological role of insulin in the body leads you to this conclusion. The general role of insulin was perfectly described by George Cahill in his Banting Memorial Lecture way back in 1971. For those that are finding a way to reverse type 2 diabetes without needing more pills, medications or insulin shots, you should check this secrets tutorial. I have got good results with it. About 1 month ago when I started following that guide, my blood sugar count was at 332 and my kidneys were in very poor condition. Just today I was given my results from my last physical and can report that my blood sugar count is 110 and my kidney function is just slightly elevated. By the way, I forgot to mention, when I was first diagnosed, I weighed over 250 pounds and my blood pressure was high. I now weigh 193 pounds and my blood pressure is normal. Insulin serves as the body's signal for the fed or fasted state. High insulin levels, the fed signal, initiate tissue uptake and storage of fuels. Low insulin levels, the fasted signal, initiate mobilization of stored fuels from tissue stores, the rate being proportional to the lowness of the insulin. Certain metabolic states such as obesity or trauma alter the concentration of insulin at which no net transfer of fuel occurs, resulting in insulin resistance or hypersensitivity. Quote, Physiology of Insulin in Man, The Banting Memorial Lecture 1971. Our understanding has been refined to some extent since then, but the basics are well described. In fact, where our knowledge has improved the most is the mechanisms underlying the impaired action of insulin. As it seems now, as soon as, especially superficial, below the waistline, subcutaneous fat depots fail to take up and store lipids, fat, in an appropriate, insulin-sensitive way, these lipids get deposited in less appropriate places. First, in deeper subcutaneous, then visceral, epicardial, etc. Adipose depots, and if those become full as well, fat starts flooding all insulin-sensitive organs, such as the liver, the pancreas, and the endothelium, the inner lining of blood vessels. This, so-called ectopic, fat deposition is the root cause of all associated symptoms and malignancies, starting from reduced clearance and increased release of insulin, elevated blood sugar, and until late stages also insulin, chronic low-grade inflammation, and so on. These latter symptoms give rise to downstream sub-diseases, atherosclerosis, neuropathies, nephropathies, ulcers, etc. In short, diabetes is the direct result of insulin's failure to properly shuttle and hold lipids in the most benign places within the body, superficial subcutaneous adipose tissue. There is a lot more to this. For instance, the difference between sexes is quite substantial, especially between premenopausal women and adult men, so sex hormones play a significant role, too. Based on above understanding, namely that diabetes is a fuel partitioning disease resulting from adipose tissue buffer dysfunction, reducing the need for partitioning incoming fuels in the diet can yield dramatic short-term results, at least as far as symptom and downstream effect management is concerned. Consume adequate protein in each meal, add carbohydrates and fats well separated. You can go whole food, low carbohydrate with some fruit indulgence between meals, I mean beyond the absorptive period 4 to 6 hours, or go very low fat, plant-based. Whatever you find easier to adhere to, making sure that all essential nutrients are included, both should work. Personally, I find a low-carbohydrate, high-fat diet easier to follow, but individuals are different with respect to genetic makeup, gut flora, and social food preferences. Regarding long-term outcomes of such restrictions, there is not much data available, but the average turnover of subcutaneous fat is 8 to 10% per year, so it might take as long as 8 to 10 years to fully reverse the condition even with strict adherence applied. And now I'm obviously talking about type 2 diabetes only. Another straightforward question to ask is what causes this disease of partitioning. My best guess so far is that one major contributor is the ever-increasing proportion of ultra-refined foods that are high in both quick-absorbing carbohydrates and fat in the diet. This combination, very high insulin response together with a substantial amount of fat delivered, is non-existent in nature, and over time it breaks our metabolism that is still not adapted to such an ongoing insult. Most likely other factors contribute as well, from sleep disturbances to lack of exposure to more extreme temperature conditions, a low level of lean mass, etc.